speaker I'd like to introduce Dr. Harold Gelb graduated from New York University and achieved his Bachelor of Science degree there, and graduated from Tufts University School of Dental Medicine, graduated there cum laude. He's been awarded fellowships in the American College of Dentists, the International College of Dentists, and the Academy of General Dentistry, and is a diplomat of the American Board of Orofacial Pain. He's currently a clinical professor at Tufts University and was formerly clinical professor in the Department of Restorative Dentistry at the University of Medicine and Dentistry in New Jersey. He served as the director of the Temporomandibular Joint Clinic at the New York Eye and Ear Infirmary for 22 years. He's the founder of the Dr. Harold Gilt Craniomandibular Pain Center at Tufts University, College of Dental Medicine. He's former professor of Temple University here in Philadelphia. When you look through Harold's curriculum vitae, if you haven't heard Harold Gelb speak in your professional career, your education is woefully inadequate, and you really need to be here today. He has spoken at virtually every dental college in North America. He speaks all over the world today, in the Pacific Rim, Europe, and so forth. I don't know of anybody who's given more of his time and expertise and his generosity to educate our profession like Harold has done. He has served as general chairman of the Greater New York Dental Meeting. He's past president of the American Academy of Craniomandibular Disorders, past president of the American Equilibration Society. He edits a variety of different journals, including Cranio, the Journal of Craniomandibular Practice, Dental Clinics of North America. He's even authored several books, including Clinical Management of Head, Neck, and TMJ Pain and Dysfunction. That is the book on TMJ, the textbook. It's kind of like the Gone with the Wind of dental textbooks. Also a book that was put out for the general public called Killing Pain Without Prescription. I can tell you that when I met Harold Gelb back in the late 70s, I was in general practice and teaching at Georgetown, and he came and gave a conference there, and it changed my life. And I think there's no one in the profession, in the health profession, that I owe more to, that I have more respect for or more love for than Dr. Harold Gelb, and I wish, I'm really honored to be able to introduce him to you. Give him a warm welcome.
Thank Rich, the members of the IAOMT, Mark Briner, for this wonderful invitation. Sorry my mother wasn't here to hear that, Rich. It was very nice. I finally, after I listened to Murray Vimy, I finally understood why I was invited to speak here. My initials are HG. So it finally dawned on me, that's why I was finally invited to come here. I got started in this field back in the early 50s. In this area of temporomandibular disorders and orofacial pain. I was called back into service a second time, and I spent time with the Army as a prosthodontist during the Korean War. So I was in Japan and Korea. And we had like a GI Bill, and they gave us the right to take courses. And one of the courses I took right after getting out of service was a course given at a proprietary school in New York called the Institute for Graduate Dentists. I had taken courses with them before in practice management, and they gave a course called Oral Orthopaedics. It was a one-year course, or one every week. They showed no patients, but the theory really impressed me. They were looking not at teeth as they relate to one another, but the jaw, the head, the neck, the spine, the entire body. And the individual that probably contributed most to this was an individual by the name of Victor Stoll, who happened to have been a dentist who emigrated to this country from Germany. He was a mechanical engineer, and he came up with the importance of correct jaw relationships of cervical orofacial orthopedia. And this was published, let's say, in 48. Prior to that, there was a British orthodontist by the name of Arnold Novy, who published a series of articles in the Dental Record, which was a British publication. And the article was entitled Cervico-Facial Orthopedia. He was the honorary orthodontist to the Willesden General Hospital, orthodontist research worker at the Royal Chest Hospital in London. And this is what he said. And mind you, this was roughly 50 years ago. But as you well know, with the problem that you had, things don't change rapidly in the professions, especially ours. And what he said about this was that the purpose of this communication is to first to state why, in the writer's opinion, classic orthodontia cannot resolve with certainty the morphological tangle generally associated with malocclusion. Secondly, to discuss the principles underlying the wider concept assumed in cervicofacial orthopedia, which aims at a reduction of a state of imbalance between the internal and external structures of the head and neck by appropriate means in accordance with the accepted procedure in general orthopedia. And lastly, to describe the practice application of this concept as a form of therapy based on accepted physiological criteria. So the problem really isn't much different than the problem that you people are dealing with on a daily basis. So I will try to take you from that time to the present time, some of the experiences we've been through, how the profession has changed in its look at this situation, and to try to untangle a web that exists today because of a conflict that exists between some of the people in the academic community and some of the people in the clinical community as it relates to this problem in its present-day concept. So let's just turn on the slides and we'll get going. Can I have the projectors, please? They're on? The first slide on the left shows somebody coming down to earth in a parachute, and underneath it says, the mind is like a parachute. It functions only when open. So if you're going to present any material to anybody, you're trying to give them an idea of what you're speaking about, they have to have an open mind, and it's very difficult to undo 4 years of a professional education, whether it be an hour and a half, whether it be a day, whether it be 2 days or 3 days. It's going to take longer. That's why people go around and take courses on weekends and then suddenly become experts, which I don't think they're qualified to do. A course gives you an introduction, and then the clinical experience is what develops you into the type of individual that you're going to be in that particular field of endeavor. Yeah, that one is going. Let me just see this. Okay, let me just go back one here. The head and face are subject to chronic, persistent, or recurring pain more often than the other portion of the body. And this shows you various nerves coming out of the brain, and roughly we have 12 cranial nerves. The fifth nerve, the trigeminal, by volume, makes up 50 to 60% of the tissue of all 12 nerves. So the impact on the central nervous system and sympathetic or autonomic nervous system is mammoth. It also innervates the dura of the brain. So just as you have a problem with mercury and its effect on different organ systems in the body, this is of paramount importance to its effect on a total individual, head to toe. There was a report done back in 1986 or 85. It's going to turn. There was a new brain report, and this report showed, let me just be sure I got everything going here. I really don't need that. American workers in the United States at that time lost 550 million days a year because of pain. And these are their most common complaints. Headaches, 156.9 million days a year. Backaches, 88.8. Muscle pains, 58.2. Joint pains, 107.8.
The N button.
Got it. Joint pains, 107.8. Stomach pains, 98.7. Menstrual pains, 28.5. And dental pains, 15.1. If you're a conventional graduate from a dental school today, I would say that your scope would stop right there. However, if you understand the implications of the trigeminal system and other effects that it has on the rest of the body, you would be involved with all of these except maybe the menstrual pains. You would have an impact on all the others. Now, headaches break down into three major categories. 2% are traction inflammatory, 8% are vascular, and 90% are muscle contraction headaches. Of those three types of headaches, we will treat this better than any other health professional practicing today, whether it be this country, Canada, Europe, Asia, South America, Australia. That's part of our field. And what has happened today, the physicians have recognized this and have given us, so to speak, the right to operate in these areas. Now, there are in the United States today 40 to 50 million chronic headache sufferers. 40 to 50 million. Dentistry treats many more patients, but on a dollar-wise basis, it doesn't compete. Dentistry as a profession today may be a $43 to $45 billion a year industry in its totality. Chronic pain is somewhere up in the neighborhood of 90 billion. And if 40% of that affects the head and face, you're talking about a lot of money and a lot of sick people. And if you're talking about 40 to 50 million chronic pain sufferers with headache, 90% of 40 to 50 million is another 36 to 45 million people that could have access to your practices for a problem that you will treat better than anybody else. Now, you spent the time to go to dental school, you worked hard, you have a background in the field, this is your birthright. Why not take advantage of it? That's all that I'm saying. I looked at patients for roughly 20 years. First 20 years I was in this field, and I bought what everybody else said. No two people are alike. We're all asymmetric. And I bought that. And one of the gentlemen here said, gee, I remember you lecturing, I think it was in the early or mid-'80s, and you were saying what you saw, and you tried to explain it. And I originally thought that was why it happened. So after looking at people for 20 years or so, I looked at them, I woke up one day and said, they're all off on the same side. So what did I see? So a higher right eyebrow, a lower left, a higher right eye, a lower left, a larger right eye, a lower left, a higher right nostril, a lower left, a larger right nostril, a smaller left, a higher right earlobe, a lower left earlobe, lower right shoulder, lower right breast, lower right hip, and what appeared to be a shorter right leg on the right side. And I used to think, because I wasn't, into it to the extent that I am today, I knew that in the North American continent, everything above the equator went to the right, everything below the equator went to the left. I knew that all the rivers that flowed north to south would wear away the right bank faster than the left, and I knew that all the vines that would twirl around trees or trellises would twirl around to the right above the equator and to the left below. So I said, this must be the factor why I'm seeing all of this, but that was not the factor. And there was an ear, nose, and throat specialist who was on the faculty of UCLA who enlightened me and said, Harold, it all happens the day we're born. We come through left shoulder, left head first. So other than a cesarean, most of the patients I see have this appearance and a postural imbalance, which, after examining now in the clinics that I worked at in private practice, probably in the last 42 years or so, I've probably seen over 20,000 patients. And I know pretty much where they're going to hurt before I even examine them. And I verify it on every examination. And I can tell you exactly the spot, so if time permits, I will try to go through these slides as quickly as possible, maybe pick a person or two or three out of the audience and show you exactly what I see every day in my practice. So this is the way we start. And then lo and behold, you find that the teeth do not erupt into the oral cavity to their full genetic potential. And you don't always see nice heads like this. All of you who have children looked at them shortly after they were born, and some of them had crazy heads like the others. Now, when I stand the people up, and I look at their heads, most of the heads are forward of the vertebral column. So almost every patient coming into my office has a forward head posture. And along with that, the muscles that attach to the back of the neck are stretched. The ones going down from the chin down to the sternum are foreshortened. You have a forward head, and generally you get a normal rotation of the mandible upward and backwards. And if you divide the face into three, the lowest third, or the smallest third, would generally be the one underneath the nose going to the chin. So certain things started to develop in your mind, and you start to put a whole picture together. And you see this young girl with an occlusion like that. Well, it all depends. What would you do here? I would bring the mandible forward, orthopaedically, to its corrected jaw relationship, whereas in orthodontics, they may pull out two bicuspids and move the 6 upper front teeth back. So a lot of these things that you're seeing on a daily basis, and my office is loaded with some of these failures, it took 1 billion years to develop low back pain. We started in 4-legged animals, much easier to balance your weight over 4 legs. And as we got more upright, we are now balancing a 9 to 15 pound head on a skyscraper skeleton. Very difficult to do. Throws off all the muscular components from head to toe. So we're now dealing a problem that starts here, and now also involves what's happening in the feet. And to establish balance head to toe, both of these areas must be kept in thought at all times. And of course, you can see as we evolve, the face changed, the head changed, the size changed, the mandible changed. And you can see some of us who have this kind of a hairdo are closer to future man than some of you with all that stuff on top of your head. All right, so we started to look. Can we just clear that up a little bit? Okay. And this is what we saw. We're trying to figure out, why are we seeing what we're seeing? Why are we seeing it in the numbers in which we're seeing? And it probably starts at an early age with an insufficient airway, large tonsils and adenoids, deviated septum. Then you have children who have habits like sucking on thumbs, fingers, pacifiers, and blankets. Children fall out of tree houses, sliding upon swings, monkey bars. They get hurt in some early contact sports that they engage in. They develop a forward head posture. They mouth breathe. They have a lower tongue. Most of them have maxillary constriction, and we have dental cracking. Now, this is associated with vertebral column compression, a retruded mandible, weakening of the posterior neck muscles, clenching, grinding, and bracing, which Murray brought up, which you see, which I'm glad is better with an appliance in the mouth, because it gives me another reason to put an appliance in. Distalization of the condyles and pain, and the distalized condyles represent a loss of vertical dimension. We also have associated with this insufficient posterior alveolar bone growth, foreshortening of the muscles at the front of the neck. You get muscle constriction throughout the jaw, head, neck, back, right into the legs. And if you add to this all forms of stress, you have patients that are climbing the walls. But that's not good enough. We have to make it a little worse. So we do bicuspid extractions during orthodontic therapy, which the orthodontic community feels there is no correlation with this problem, but I have several hundred cases now that I'm trying to find the time to write the paper on, and I know, this is anecdotal, it's anecdotal, but I feel in my soul, by what I see and by the examination that I've done, that there is a close correlation with some of the other problems that you see in here. So we're dealing with a multifactorial problem that requires a multidisciplinary approach. So you have to understand that. And as part of what Murray told you about certain statements that are made by certain people, you can't go up and just say something without the scientific verification. But these are things that clinically have become quite obvious to me. So we're seeing forward heads. We're not seeing the plumb line of the body goes through the TM joint, just forward to the tragus of the ear, through the shoulder, through the hip, anterior to the knee bone, and through the ankle. But many of the patients look like this. So some of the things you're going to see patients who have scoliosis and other problems that can be related to a certain extent to what we're doing. And that's the way they should be. This is from Janelle Travell's book, and it shows you somebody who has one leg shorter than the other. And when you see people stand, especially the women, when they stand and wait for a friend, they put the weight on the short leg and stretch out the long leg. So I said they couldn't all have taken ballet lessons, because they all stand like this, or they stand like this. And basically, almost everybody does that. Who's off? Just be a little bit more attentive when you look at them, because that's one of the things you see. So it may be that a lift has to go in to the short leg shoe at the same time that you're making a correction here to evolve into a perfect postural correction, which helps to get rid of most of the symptoms. Now, what I do at the consultation visit, analogous to this, is I already have my study models. I've taken the x-rays because I already know what's wrong. I've done a clinical exam. I do a three-dimensional analysis, make a wax bite, put it in at the consultation visit. I've already examined all the muscles in the body. The patient is now kinesiologically stronger, which we verified scientifically at the New England Medical Center. I've got the documentation. They're stronger. And the pain leaves almost every single muscle group in the entire body when the jaw is in the right position before an appliance is ever made. So the patient and I both know that the treatment has a high degree of success, anticipated success, before the therapy is ever instituted. The problem is orthopedic. You would use some of the ramifications of physical rehabilitation medicine. There'll be physical therapy, there'll be exercises, but things of that sort. But most of these patients get well in a matter of 90 to 120 days. Mariano Roccabato from School of Dentistry in Chile wrote several articles that one was published in Cranio, the one on the right here, biomechanical relationship of the cranial, cervical, and hyoid regions, and another one is on arthrokinematics of the temporomandibular joints, which was in the second edition of my book, Clinical Management, published in '85. And these are some of the things that he saw as a physical therapist. He's working in the orthodontic department at the University of Chile Dental School. So it's possible now to verify a forward head posture on a cephalometric x-ray. This is the McGregor plane right here, posterior nasal spine to the occiput. This is the odontoid plane. This angle in here in a normal patient with a normal head-neck posture is 101 degrees, plus or minus 5. C1 and C2 do not line up with 3, 4, 5, 6, and 7. If you take a line and you make a triangle from retrognathon on the chin to the base of C3 to the hyoid bone, it should be a positive hyoid triangle. As the head moves forward, that triangle disappears. It's obliterated. C1 and C2 start to line up with 3, 4, 5, 6, and 7. The space between C1 and the occiput should be 4 to 9 millimeters. They almost touch. So now, on an x-ray, you can see whether I'm dealing with a normal head neck relationship besides the tracing, besides the supplementary tracing you're going to get, but to verify what we're doing and to see if it's correct. So these are some of the things you now see in some of these patients. Normal craniovertebral relationship with an inverted cervical curvature. Extension of the craniovertebral joints, and you get a reverse cervical curvature. So when I take a cephalometric x-ray, I'm more interested in the head-neck relationship than I am in the tracing. It's only after the patient has to be turned over to somebody to maybe stabilize the case more permanently on a permanent basis, where orthodontic therapy may be indicated, that they would look at it a little bit differently. Here is a normal craniocervical relationship with a straight cervical spine. Now, you're playing a tremendous role in correcting some of the things that I'm showing you now. You're going to see some before and afters here, and you're going to see how it affects the whole spinal column. You see befores on the left and afters on the right. Before, it's curved in the center. After, before, after. So you're seeing some of the things that can happen when you make the type of changes that we're discussing as you're taking care of these patients. And you'll see changes in the curvature of the spine before and after, and in the curvature of the spine, looking at it in profile as well. This is a 15-year-old boy who had scoliosis. He had about a 15-degree curve at the beginning of treatment. He was seeing an orthopedist. The orthopedist didn't know. This was done by a friend of mine, Richard Kaufman, orthodontist. Put in an appliance, treated him. This is the curvature. It was 15 degrees. And 6 months later, the curvature was down to 3 degrees. And all we did was use appliances to correct a temporomandibular disorder that the orthopedist wasn't aware of. This is a minister. His right leg is 3 inches shorter than the left. This is him before. This is him after. This is him before. This is him after. Now, mind you, you're dentists, but this is what you're capable of doing, except you never had this dimension of education at the undergraduate or postgraduate level, and it's got to be considered. All right, so we've now graduated to a point today where the physicians recognize the role that we as dentists play in this field. The International Headache Society and the American Association for the Study of Headache have classifications for headache disorders, cranial neuralgias, and facial pain. They break down into 13 categories. Now, we go from migraine to tension-type headache, cluster, etc., etc., etc. Headache associated with non-cephalic infection, headache associated, and we come to number 11, which is strictly all dental. This is all dental. Headache or facial pain associated with disorder of cranium, neck, eyes, ears, nose, sinuses, teeth, mouth, or other facial or cranial structures. And they've also given us part of number 2, tension-type headache. So the physicians, many of whom are neurologists, of course, in the International Society for the Study of Headache, know that the dentists play an important role in some of these headache entities. That is one of the things that's happened, I would say, within the last 3 or 4 years, which I think is extremely good. Now, there's a TMJ of craniofacial pain diagnostic classification. And it breaks down into 3 major categories today: somatic, neurogenous, and psychogenic. So as far as what you and I are going to see, the bulk of the patients that you and I are going to fall into the somatic category. They'll either be masticatory, which will be myogenous muscle, or arthrogenous joint. So you'll have myalgia, myofascial pain and dysfunction, myositis, trismus, sustained spasm, contraction, and then you'll have deviation and form disc displacement with reduction, without reduction, inflammation, synovitis, capsulitis, etc., retrodiscitis, hypermobility, degenerative joint disease, fibrous ankylosis, and bony ankylosis. And still in that same category, we have cervical. So you can't practice dentistry anymore with at least going down to the shoulder girdle. I take in the whole body, but I would expect the average dentist to at least be able to go down to the shoulder girdle. And it involves myalgia, myofascial pain, cervical sprain, cervical spine dysfunction, retropharyngeal tendonitis, all of these things. Thoracic outlet syndrome, cervical radiculopathy. And there are systemic factors: fibrositis, arthritis, connective tissue disorder, polymyalgia rheumatica, and calcium pyrophosphate deposition disease. That is the somatic category. Now we got neurogenous, and we got psychogenic. Now, these patients cannot be treated the same way the other ones I just showed you are treated. These are treated mostly with different types of medications.